Namaskaram everyone. Today I shall be discussing about the NICE guidelines on the epilepsies in children, young people and adults, and I have mentioned the recommendations which are pertaining to the children only because mine is a pediatrics channel specifically, and these are the latest guidelines which have been given on the year in the year 2022 as published on 27th of April. So as far as the diagnosis and assessment of epilepsy is concerned, an individualized assessment of the risk of a second seizure should be done, including any mental, physical, and social factors identified as possible risk factors and assessing how these could be modified. Some modifiable risk factors which are present in adults and which we as a pediatricians should know because our children shall be progressing to adulthood are as follows. First is an underlying mental health problem like depression, anxiety, psychosis, and alcohol or substance abuse. Vascular risk factors like diabetes, hypertension, and atrial fibrillation, and sepsis. One must be aware that if a child is presenting with the first afebrile seizure, then there is an increased risk of further afebrile seizures, especially within 6 to 12 months of the first seizure. Also, any child presenting with a complicated febrile seizure, that is a febrile seizure lasting for more than 10 minutes or associated with any focal neurological deficit, is an increased risk of epilepsy, especially if he has other predisposing risk factors for the same. After the first seizure, a pediatrician should give the person, that is the patient and their family, the following information. That is, how to recognize a further seizure, first aid and initial safety guidance in case of another seizure, and any changes they can make to reduce the risk of seizure in their child. Then we must take a detailed history from the child after first suspected seizure and carry out a physical examination. If possible, and it is generally recommended that we must use eyewitness accounts and preferably see a video footage of the seizure activity to complete the assessment. Metabolic disturbances like hypoglycemia and hypocalcemia can also sometimes lead to seizures, and these must be ruled out. Brain neuroimaging should be offered to any child with a suspected structural cause underlying it. A routine EEG should be carried out while awake to support the diagnosis of epilepsy. Remember, EEG is never performed to exclude the diagnosis. That is, if EEG is normal, then we say that epilepsy is not there, is not the norm, because even 30 to 50% of normal people can have an abnormal EEG, and epileptic patients of the same magnitude, that is 30 to 50% of epileptic patients, can have a normal EEG at a particular time. So we cannot exclude the diagnosis of epilepsy if the EEG is normal. Rather, we must use EEG as a supportive evidence to epilepsy. So if an EEG is required after a first seizure, it must be done as soon as possible, preferably within the first 72 hours. Also, the type of EEG which is to be done is as follows. We must first go for an awake EEG. If we do not get the abnormality in awake EEG and we are strongly suspicious of epilepsy, in that case we may go for an awake EEG with provoking maneuvers. Provoking maneuvers are like hyperventilation and photic stimulation, and this we must do only after consultation with the parents or caregivers. If still not, then we may go for a sleep deprived EEG, and if still not, then we may go for ambulatory EEG up to 48 hours of the onset or the presence of the first seizure activity. An MRI should be offered to all children who have been diagnosed with epilepsy unless and until we are sure on an EEG that the patient has an idiopathic generalized epilepsy or self-limited epilepsy with centrotemporal spikes, which is a benign kind of epilepsy referred to as PETs. If at all MRI is contraindicated, then we may go for a CT scan in children with epilepsy. MRI scan should always be preferably reported by a radiologist who has an expertise in pediatric neuroradiology, and if seizures are ongoing despite treatment and the diagnosis remains clear, a second opinion should definitely be sought. A repeat scanning can be done if the original scan was suboptimal, if there are new clinical features to the epilepsy, if the patient has proven idiopathic generalized epilepsy or benign epilepsy with centrotemporal spikes that has not responded to the first-line treatment, and if surgery is being considered for the patient. One must not carry out a CT scan for people with established epilepsy presenting to an emergency department after a typical seizure unless and until there are other concerns for the same. For genetic testing, we must discuss with a neurologist or geneticist any uncertainties about whether to offer genetic testing for a child with epilepsy, and if yes, then which tests to offer for the person. Before carrying out genetic tests, discuss the purpose of testing and possible implications of results with the parents and obtain informed consent from them with appropriate genetic counseling. Consider whole genome sequencing test for people with epilepsy of unknown cause who are below 2 years of age when epilepsy started, are aged between 2 to 3 years when epilepsy started, and if clinically agreed by a multidisciplinary team, or have clinical features suggestive of a specific genetic epilepsy syndrome, for example Dravet syndrome, or have additional clinical features such as a learning disability, autism spectrum disorder, a structural abnormality, for example dysmorphism or congenital malformation, or an unexplained cognitive or memory decline. Antibody testing should be considered in discussion with a neurologist for people with new onset epilepsy, if at all autoimmune encephalitis is suspected, for which I have already made a detailed video on the channel. People with epilepsy should be given information about the details of local and national epilepsy information and support groups, triggers that may provoke seizures, medications for epilepsy, the importance of adherence to medication, which is very important to be trained to a population like ours, and the possible side effects as well. Reducing epilepsy related risks, including sudden unexpected death in epilepsy, which is known as UDEP. Impact on daily activities including driving, information about their epilepsy syndrome or seizure types, and we must also provide them with a copy of their epilepsy care plan. We must discuss issues which concern them. For example, activities of daily living, safety issues like showering rather than having baths, cooking safely, caring for babies and young children safely, and avoiding working at heights, supervised swimming and water sports and not climbing above their height without supervision, driving, employment and education including concerns and rights related to employment and education. Then caregivers, physical and emotional demands of caring for and supporting a person with epilepsy, and information and support for caregivers including assessing caregivers' needs. Concerns about the impact of epilepsy and antiseizure medications on cognitive functions including memory, attention, concentration, educational attainment and performance in the workplace. Adherence to antiseizure medications and how to improve this, and experiences of side effects from medications and coping strategies in explaining changes to medications. Mental health like emotional health and psychological well-being, neurobehavioral disorders including autism and ADHD, and any stigmatization of epilepsy. Then also reproductive health and pregnancy, like providing support and information on contraceptives and pregnancy for females and their partners to enable them to make informed decisions, changes in medications and the potential interactions with contraception, teratogenicity of anti-seizure medications, preconception planning, including the use of folic acid and reducing epilepsy-related risks during pregnancy, planning the birth, postnatal care and breastfeeding. Concerns of people about sudden unexpected death in epilepsy, that is UDEP, and information about the same. Now, one must develop an individualized anti-seizure medication treatment strategy for every patient, taking into account the sex and age, seizure type and epilepsy syndrome, whether treatment is needed, the risks and benefits of seizure medications, anti-seizure medications, and possible interactions, and how and when the antiseizure medications need to be taken and discontinued. Any comorbidities, preferences of the person and the family or carers if appropriate, and personal circumstances like education, employment, likelihood of pregnancy, and travel. One must start treatment with anti-seizure medication once the diagnosis of epilepsy is confirmed, and one must consider starting treatment after a first unprovoked seizure if any of the following apply, like a neurological deficit, EEG showing unequivocal epileptic activity, after a discussion of the risk of further seizures, the person or the family or the caregivers consider the risk unacceptable, and the brain imaging shows a structural abnormality. If monotherapy is unsuccessful, then we may escalate the therapy by adding an add-on treatment. When starting an add-on treatment, we must carefully titrate the additional medicine and review the treatment frequently, including monitoring for adverse effects such as sedation. If add-on treatment does not result in reduction of seizures, we must use the regimen that provides the best balance between effectiveness and the tolerability of side effects, and discuss with the person and the family about the benefits of taking as few medicines as possible to maintain seizure freedom or control. Now, the principles of de-escalating anti-seizure medications involve using a single anti-seizure medication as far as possible. If first-line monotherapy is unsuccessful, then we must first review the diagnosis of epilepsy, whether or not it is there. And if the diagnosis of epilepsy is confirmed and trial with the monotherapy has failed, then we must consider adding on another drug with caution during the changeover period. Increase the dose of the second medicine slowly while maintaining the dose of the first medicine. So first medicine should not be stopped abruptly like many of the PG students they do. Rather, the second medicine should be added and the same dose of the first medicine should be maintained unless and until the drug levels of the second medicine build up in the blood. If the second medicine is successful, then we must slowly taper off the first medicine. But if the second medicine is unsuccessful, then we must taper off the dose of the second medicine first and then consider an alternative to it. Now, anti-seizure medications for women and children. One must review regularly the information provided about contraception, folic acid supplementation, conception, pregnancy, breastfeeding, caring for children, and menopause. Like drugs like sodium valproate, they have an increased risk to the unborn child. Some anti-seizure medications like carbamazepine, oxcarbazepine, phenytoin, and topiramate can impair the effectiveness of hormonal contraceptives. And we must support each mother to choose a feeding method that best suits her and her family. Breastfeeding for most women and girls taking anti-seizure medications is generally safe and should be encouraged at all costs. We must discuss monitoring reviews with children and young people with epilepsy and their families and agree a frequency for regular reviews that is individually tailored to the child's needs, preferences, and the nature of their epilepsy, and at least every 12 months, that is once a year. We must consider monitoring anti-seizure medication levels if people with epilepsy has any of the following, that is uncontrolled seizures, side effects from their anti-seizure medications, a specific clinical condition needing a closer supervision like pregnancy or renal failure, and poor adherence to medication. After a person has been seizure-free for 2 years, we must carry out an individualized assessment to determine the risk of seizure recurrence if anti-seizure medications are discontinued. The plan should include reducing their anti-seizure medications gradually, and this is over a duration of 3 months at least for most of the medicines, but a longer duration for benzodiazepines and barbiturates because of the risk of precipitation of withdrawal symptoms. For multiple anti-seizure medications, we must discontinue the medications one at a time. If seizures recur during or after discontinuation, then we must reverse the last dose reduction first. After epilepsy surgery, we must discontinue anti-seizure medications only under the guidance of the Epilepsy Surgery Center. When we begin planning transition from children to adult epilepsy services, we must plan the same early for those children who have complex or additional health and social care needs, for example, whose seizures are not yet controlled in their childhood, or those who have learning disabilities. During the transition, the pediatric and the adult multidisciplinary teams should jointly review the person's diagnosis and management plan. So to summarize, the NICE Guidelines 2022, which are the latest guidelines for the management of epilepsy, a child with a first afebrile seizure is an increased risk of having further afebrile seizures, especially within 6 to 12 months of the first seizure. Child with complicated febrile seizures is at a higher risk of epilepsy, especially if risk factors are present. An EEG should be done to support and not to make or to exclude the diagnosis of epilepsy. And the pattern which should be followed is preferably an awake EEG. If not, then awake with provoking maneuvers like hyperventilation and photic stimulation. If not, then sleep deprived EEG, and if still not, then ambulatory EEG. An MRI scan should be done in children diagnosed with epilepsy unless they have idiopathic generalized epilepsy or self-limited epilepsy with centrotemporal spikes which are proven on EEG itself. One must start treatment with an antiseizure medication once the diagnosis of epilepsy is confirmed. And one must consider starting treatment after a first unprovoked seizure itself if there is neurological deficit, unequivocal epileptic activity on EEG, if the person or the family considers the risk of leaving the first seizure untreated as unacceptable, and the brain imaging shows a structural abnormality. If monotherapy is unsuccessful on treatment, then consider trying an add-on treatment, carefully titrating the doses. One must review the diagnosis of epilepsy if seizures continue despite an optimal dose of first-line antiseizure medication. If first-line monotherapy fails, then another antiseizure medication must be given, as already said. Increase the dose of the second medicine slowly while maintaining the dose of the first antiseizure medication. If the second medicine is successful, then slowly taper off the dose of the first medicine. If, however, the second medicine is unsuccessful, slowly taper off the dose of the second medicine and consider an alternative. Consider monitoring antiseizure medication levels in people with epilepsy with uncontrolled seizures, side effects from the seizures from the medicines, a specific clinical condition needing closer supervision like pregnancy or renal failure, and poor adherence to antiseizure medications. After a person has been seizure-free for 2 years, one must carry out an individualized assessment to determine the risk of seizure recurrence if antiseizure medications are discontinued, and one must plan transition early for those who have complex or additional health and social care needs, example young people whose seizures are not yet controlled or those with learning disabilities, while transitioning them from pediatric to adult epilepsy care providers. Thank you so much for a patient watching and listening, and please do share the knowledge. Thanks a lot.